And we're live, everybody. Welcome to yet another episode of hashtag SPSM, Suicide Prevention Social Media Chat. I'm very excited tonight. We're meeting somebody tonight that I have just met, but is not new to Stark or new to Pocket Square. Oops, I've got the wrong camera on. Not new to Pocket Square. Let me tell you, we have Dr. Virna Little with us tonight, and here's the deal. If you are the kind of person like me who gets a little verklempt about electronic medical records and about really doing good case management, you know, being able to use data to drive really well-informed care, and you want to know how to be clever about that, this is your episode. So definitely do hashtag SPSM, but do consider doing hashtag HITSM, Health Information Technology and Social Media, or hashtag HIT, Health Information Technology. And we want to really thank @4Family Health, the Family Institute, or the Institute of Family Health. I'm going to get it wrong because, you know, it's family, there's health, there's institute in it, but Virna's going to tell you more about it because these folks have a really good healthcare social media presence, and they have given us Dr. Virna Little tonight. Want to remind everybody that Misha Kessler, @Misha Kessler, is down from Mount Everest, and we're coming up with what we think we're going to do with the SPSM flag that went to base camp. We're so excited. And that you can also earn badges by participating, and we've been tweeting out links to all of that. And wait, there's more. We, of course, have @Bart Andrews, Dr. Bart Andrews with us tonight, but we also have a brand new guest mod from the hashtag Zero Suicide crowd. Feel free to use hashtag Zero Suicide. We have Sarah Bernes, you and I know her as Stark, has joined us tonight to help moderate. What this means, because Virna is a little newer to me, is that Stark and Pocket Square are going to be helping drive the conversation with her while I try to catch everything by Twitter. And as always, everybody, and he's not live down below, Tony Woods @ADWWW, if you have questions or comments that you would like to get to our live guest tonight, that is the guy that you want to tweet. Tony, take yourself off mute and say hi to the people.
Hello, people!
Ah!
Wow, that was loud.
What can I say?
Tony, how's everything going in Kansas?
Golly, it's dandy.
Tell everybody where you are and what your title is real quick.
The fall is fallen. Production director, co-founder. You're lucky. You're all so lucky to be here tonight. Simply because I got the tech to work.
Yay!
Yay!
You're a tech director.
And my corner where I belong. Bye, guys.
We'll see you. And we have Dr. Bart Andrews. Bart Andrews.
Good evening, everybody. Super excited to be here. I'm super excited because when I first got involved with Missouri's Zero Suicide Initiative, one of the first names to pop up was Virna Little. So the group at the Department of Mental Health in Missouri were like, well, you've got to meet Virna Little. And I'm like, who is Virna Little? And when I went to the Zero Suicide Academy this June, I got to see Virna talk about healthcare records, about suicide prevention and taking a system approach, and people in the room that were, I think, sometimes not really sure why they were there when they heard Virna talk, all of a sudden everything clicked for them. And
yeah.
So
when you hear suicide and medical records, that doesn't sound like a party.
It doesn't to most folks, but it can be, and it should be. I mean, we saw Doc Foreman losing her shit earlier over this whole concept, and it was, I wish we had that on tape because that was beautiful. But I'm really excited about Virna being here tonight. I'm very excited about the amazing Sarah Bernes being here tonight. Virna and Sarah and I were at the Atlanta Zero Suicide Summit Monday and Tuesday, and that was an amazing experience.
And you were a conference like live tweeting social media crew.
We were so Sarah is a rock star when it comes to live tweeting. And between the two of us, we did a pretty good job. I think when I last checked the numbers, Sarah Bernes and Virna Little, we were over 11 million impressions for the week on the Zero Suicide hashtag. And we were at like 500 participants and over 100,000 in terms of reach. That's pretty impressive.
I feel like it's adequate.
Yes, it was amazing. So having Virna here tonight and having Sarah here tonight on that wave of zero suicide goodness is very cool, and I'm really excited to be here. You can reach me at Bart Andrews.
Suicide prevention goodness.
Suicide prevention goodness. It's good stuff. It's amazing.
Oh, sorry. Say your name. Say your Twitter handle and title real quick. I'm sorry.
It's complicated. At Bart Andrews.
And you are the.
Who am I? Why am I here? I'm the vice president. I'm the vice president of clinical practice and evaluation at an amazing crisis agency in St. Louis, Missouri, Behavioral Health Response. I don't know if I told you guys this last week, but it's official. We're now rolling out and got a grant to roll out suicide follow-up to all callers on our DMH crisis line. So we're going to be increasing follow-up to about 1,000 more lives per year. And we're going to start, the implementation will start in October, and we're going to be doing acute follow-up with those folks for 4 to 6 weeks, and then we're going to do yearly follow-up with them, kind of like a phone version of the caring letters. And I think it's the first time that a phone version of that's been evaluated. So it's a pretty big deal. We're very excited and cannot wait to get started.
Like I said, Bart, adequate.
Yeah, it's all right.
And tonight, our third mod, for the very first time ever, Stark! Introduce yourself.
Hello. They all call me Stark. My real name is Sarah Bernes. I work at the Suicide Prevention Resource Center on the Zero Suicide Initiative, although all opinions expressed this evening are my own. Bart and April have referenced a bunch of things so far that I just want to clarify. Zero suicide, hashtag zero suicide, is suicide prevention for health and behavioral health care systems. Virna will talk about this a little more, but it's really making sure that suicide prevention is seen as a core responsibility of healthcare. If you'd like to check us out, you can go to www.zerosuicide.com. There's all sorts of tools and resources there for healthcare systems and a couple videos of Virna. So if you just didn't get enough this evening, you can go get more of her at zerosuicide.com.
Say that one more time.
Zerosuicide.com.
Excellent. And tell us your title really quickly.
I am a research associate at the Suicide Prevention Resource Center.
And that's Spark, and what's the website for Spark? Because that's full of great resources. We don't talk about it enough.
Yeah, sprc.org.
sprc.org and zerosuicide.com, folks. And now, somebody give me a drum roll. Somebody, somewhere. Everybody, this is Dr. Virna Little. Dr.
Hello.
Little, tell the folks who you are, because for me, this was sort of new, but I got excited very fast. Who are you? Who is the Institute of Family Health? Tell us a little bit about how you ended up here.
Thank you so much. I'm so happy to be here. This is my first vlog experience, so hopefully I'm just looking to avoid disaster. So good evening, everyone. Thank you. I'm really excited to be here and looking forward to the next hour or so having these conversations, because for those of you who know me, I could literally talk about this all night. So I will do my best to limit it to an hour. So my name is Virna. I'm from an organization called the Institute for Family Health. We are a large community health center network in New York. We're the largest community health center. We have 29 centers, and like many federally qualified health center networks, we have a huge diverse. So we have mental health centers, we have primary care with behavioral health, we have home-based services, we have WIC programs, we have homeless centers, school-based centers, so very, very diverse urban and rural setting across New York. So that's a little bit about the Institute, and we are very excited to be here and share some of the work we've done around zero suicide. And we love the partnership that we have with the Zero Suicide folks, so this is all great work.
Tell the folks the story. This is for me. This really helped. Tell the story about how you became interested in zero suicide, because that's not where you started.
No, it's not where I started. And actually, if I had it to go back again, I think one of the biggest mistakes that I made, we have been live on the electronic health record since 2002. And in 2002, I wasn't thinking about suicide across the system. I wasn't really thinking about how am I going to be able to track, oh gee, I might want to know this information 10 years from now. And so I didn't put things in the system that I even could have been in that, put in back then to help us track a little bit better. But a couple of years back, I started to sort of anecdotally note an increase, and we started to pull information from across our system. We polled, providers, we sent out emails, we looked at incident reports, we thought about all the ways we could figure out how many deaths we had in our system, and then sat down and looked at it for the first time across our entire system over a couple of years, and we thought, oh my goodness, this is not okay. And we need to do something about this, and we need to do it now, and we need to make it a priority, and we need to involve everyone, and we simply can't have this. Like I said at the time, we need to go from now to none. And so that's actually how we started the work.
And you talked about the very first time that you became aware of how many suicides there were across the system. Tell people about the first time that just sort of hit you emotionally.
I felt like it happened on my watch, and I have been in the organization for 19 years and overseeing the behavioral health services and primary care in our centers, and I thought, oh my goodness, what could I have been doing differently all this time, and why hadn't this sort of been a number one priority? And I really did. I took it very personally that this had happened on my watch, and I said, you know what, I am really going to put some resources in here, and this is going to stop. And so that has been a primary focus for us over the past couple of years, really trying to figure it out. And it's a process. It's, it's going to continue to be. It's like...
Oops, we've had just a little freeze.
She's frozen.
So we'll let Tony know we've had just a little freeze. Oh, there she is. She's back.
Yeah, so every day we just try to figure something out, and we just keep working it,
Absolutely. We absolutely keep working it. I'm going to let Bart and Sarah help you tell more of your story. You have a few more minutes to really help people know. And Sarah, I think, had some bits.
Sure. So I want to give everyone a little bit of historical background on the Zero Suicide Initiative in Health and Behavioral Health Care. You may or may not know of an organization called the National Action Alliance for Suicide Prevention. It's the public-private partnership advancing the national strategy for suicide prevention. It's individuals at the highest levels of industry and government working to move forward suicide prevention across the United States. The Action Alliance is organized into task forces, one of which is the Clinical Care and Interventions Task Force. So they got together, did a lot of research on systems like Virna's that are true pioneers in suicide prevention, and released the Suicide Care in Systems Framework. That report laid the groundwork for the Zero Suicide movement and initiative. And shortly after that report was released, Virna became involved.
Mm-hmm. And I think, like a lot of organizations, we had been screening for depression for, since 2002. The Institute was one of the first organizations to duplicate Project Impact after the research ended. So we were not new to depression screening. We were sort of not new to the PHQ-9 at all. And it was, startling to be that after doing all of that work around our depression care, that we were still in such a place around caring for patients at risk for suicide, and that our rates, were high, particularly in our primary care centers. And so that really also was another startling piece to me, that I felt like, here we were sort of starting at the beginning, even though we had been doing work for all these years. And I think we started to think one of the biggest things we did almost that very first day was put suicide on the problem list, which for primary care providers is a very basic place in the electronic health record or in the chart. And there was a lot of pushback for doing that, because there were a lot of providers, even behavioral health providers in our system, who thought that didn't belong on the problem list. But I thought there's no better way to get everybody's attention than to put it on the problem list. And what that means is, it's in front of everyone, and then everybody needs to address every problem on the problem list. I always say it's Virna's 3 E's: every problem, every discipline, every time.
Explain about, I know about problem lists because I work with an EHR that's integrated every day, but explain to people, help bridge the gap between primary care and social work, what that problem list is and how a primary care team looks at that.
So literally in every single chart, there is an area of the chart that lists all of the diagnoses that are current, and many of the EHR have them where they can be historical, so that you can go back, and if you had a problem and it was resolved, it went away, you can still see it even though it might not be active. And so putting suicide on the problem list as an active problem means that every primary care provider who sees that patient sees it front and center. And in many electronic health records, it means that it actually, what they call, blows into or appears in a note. Once the primary care provider starts to do a note for seeing that patient, the problem list often appears in that note. And so it's not only front and center in the chart, it's front and center in the note. And that can really bring attention to it. And so that we were able to do, almost right away. And that made a humongous difference.
So hold the phone, Little. Are you telling me that it is not standard to put suicide in a problem list across other healthcare systems?
No, actually, I talked to a lot of systems and a lot of healthcare providers, and even, many of them use the PHQ-9, and even if someone were to score positive on question 9, which is the suicide question, a lot of times it doesn't make it into the problem list. A lot of times they won't automatically do it. A lot of times there's concerns about confidentiality and mental health information. So there's a lot of different reasons, but no, I talked to many organizations, and unbelievably, it is not standard practice to do that.
This could kill somebody, and they don't think I should probably put that in the problem list? Because I
think about mental health organizations. Behavioral health problem lists. They might have bipolar, they might have depression, but they may not actually list suicide risk. And that's very different to add that to the problem list. If you talk to providers across the country, that is not standard practice in many disciplines. So I think that's a behavior change or a policy change or a practice change that somebody can do tomorrow, even for their own patients, even if their organization didn't start to do it.
Bart, I saw you react. Your hands went over your face.
Well, it's just so when I present, there's this slide. You got many of you know Tom Intel, who's leaving the National Institute of Mental Health, but he presented this slide a couple years ago at National Council, and it shows how much progress we've made in leukemia, how much progress we've made in stroke, how much progress we've made in AIDS, how much progress we've made in heart disease in terms of fatality rate. And then he shows all these lines that show how much the decrease is from peak level. And then at the top is the suicide rate, right, which has not budged. And he talked about bending the curve. And I think this is one of the examples why we haven't bent the curve in suicide care and we haven't reduced the fatality rate, is that we have not been intentional. We haven't made it a point of focus. So think about this for a minute. The 10th largest killer of the people that we're serving is not listed as a primary or a presenting problem in hospital electronic health records at many hospitals across the country. I'm willing to bet that less than half of the hospitals have EHR, and their EHR have suicide as a presenting problem. That's my guess. It's probably really low.
They would treat their diabetes after they died by suicide? Seriously.
It's a good question.
I can't even. Virna, you're going to have to talk more about this because I'm going to be angry.
Okay, so we'll jump in. So one of the things that we did following is that we decided, you know what, it's not enough to put it on the problem list. So now what we've done, and Epic, we have electronic health record Epic, and Epic has been an incredible partner in doing a lot of this work. And we have made the banner across the top of the electronic health record red. And it supersedes anything else. And so the minute anybody in our organization goes into that electronic health record for any patient, the banner across the top is bright red. And now they're actually it's red banner. Have you worked your red banner list? Do you see your red banner patients? Have you? And so that has actually been sort of another step that's been incredibly helpful. And I think really draws attention to, when you're seeing a patient. And also for all disciplines, we realized in one of our suicides about a year and a half ago that the last person who had seen that patient was an insurance enroller in our system. And so then we thought, well, you know what, we need to make sure everybody in our system is trained. Everybody in our system has a process when there's a red banner, and trained all of our case management, care management, insurance rollers, what to do. And how to talk to someone, how to find their safety plan, how to give them a copy of a safety plan, how to ask them if they want to talk to somebody, and some very basic processes. And so those are some things that we've, learned along the way.
Where can someone get? I'm asking for a friend. Where could somebody get a list of the things that you would recommend people do in the system when they see the red banner? Because we do that. We have that at VA, so there's a flag that comes up. But I don't know, other than telling people to be mindful of what you prescribe and that this person may be at risk, we actually don't have a prescribed set of things we train staff to do special or differently when they present at different parts of our system. Is there a place where you recommend this somewhere?
So we do, but we do it very different by discipline. So we also have the Columbia scale built in. So primary care providers do a shorter version of that. Behavioral health providers might do a longer version. Safety plans, everybody, regardless of what your position is, has to review a safety plan, and there's a way to do that. And we can actually tell in the electronic health record, I can run a report and see all of the patients with a red banner who haven't had a safety plan done in the last 30 days or who saw that patient and didn't do the safety plan, even worse. And then I can go back to them and say, hey, this is not okay, and we can do some outreach and follow-up. So, sort of really trying to follow up and putting other gaps or stop gaps in there for providers. So one of the things we're working on now is scripts. So if someone is at risk for suicide and a provider goes to write a script, there's something that pops up that says, hey, don't write for this many. This patient is at risk. And so one of the things we're going to do is put an absolute stop there at some point. But right now it's just, it's a reminder. And so starting to build some things in the system to support. So maybe we don't catch it one way, but we're catching you, sort of another way. And at some point, what I'd really like to do, if I were going to fantasize about what we might do in the coming year, if you're a red banner patient and you come in and somebody doesn't go through your safety plan, you can't close that encounter. That's it. It's absolute dead stop. You can't do anything else in that chart until you do that.
Wow.
So I don't know that everyone here knows what you mean by close encounter. I know that I do as a clinician, but not everybody is. Some folks are patients, they're lived experience, or they're from different parts of the healthcare system. What does that mean by putting a stop and preventing a closed encounter?
So whenever I go into the electronic health record and I do a note, a patient care note, and talk about what happened during that session or during that visit, and then I have to do what's close the encounter, which means I literally put an end to it, right? I close it in the system, and that means that a bill can be dropped for that service. It means that it gets filed completely in the system and in that patient's chart. And most organizations really watch the number of what they call open encounters or visits that aren't closed. It has financial implications because those visits can't be billed out, and it also ties up the system in a lot of places. And so the ability to not be able to do any more documentation or to not be able to close that encounter would really bring attention to doing that safety plan.
Yeah, and as an individual provider, like in a big system where I might be getting a salary, they check every morning to see that I closed all the encounters from the day before. So I would come to everyone's attention in a really negative light if the encounter cannot be enclosed or closed out if I didn't ensure there was a safety plan and review it.
Yeah. I mean, and the open encounters, a lot of organizations tie that to paychecks, to bonuses, to, evaluations. So the open encounters is a big deal in many organizations. Yeah. So that would be my wish list for the coming year.
Now I know why Bart says your presentations are so sexy. This is like super practical.
This is huge. Yeah. It's huge. I think the things that Virna is talking about are so powerful. And what it shows is that her agency took suicide prevention seriously. They said, hey, we need to do something about this. And instead of wringing their hands and saying stigma 30,000 times, as their solution to the suicide problem in their community and at their agency, they did really practical things using the electronic health record and built-in procedure and supporting processes, right? They were intentional and deliberate and made it a part of the core structure. And when we talk about the red banner, and when you talked about that at the academy, Virna, you could see people like, we could do that. Wheels started spinning. They're like, well, we could figure out a way to do that at our agency. And so, I mean, right now, after seeing Virna talk, we talked to our local agency that we're partnering with, Pride Health Center, about doing something similar with their folks. So when they run into somebody at their clinic, that regardless of where they are, whether they're in dental, whether they're in physical therapy, right? If there's something going on, then they're going to link them into the crisis system, and we'll have a warm handoff. There'll be a connection. That's care. That's the concept of creating a suicide care plan where everybody's involved. And that's the other thing I think is amazing is your philosophy that everybody plays a role in this, right? Every person that touches the patient.
Everybody in the organization, but also I'm a firm believer in involving the community. And so many organizations, our healthcare organizations, have what they call portals They have patient portals so that people, many of you might be familiar, can sign on to their portal and they can make appointments and talk to their doctors or their providers. There's also portals out there now that community organizations and outside physicians can get access to the electronic health records. So the Institute has over 150 organizations that have access to the electronic health record. And so if I'm in a food pantry and I sign into that patient's electronic health record, I see suicide risk on their problem list. And one of the things we've been trying to do is work with the community-based organizations to be able to then say, oh, let's look at your safety plans. You need to talk to someone. I see you haven't been in for a while, and try to have those conversations. So even if we don't touch someone and a community organization, does, then they can hopefully make a connection and engage someone back into care. So I think it's important to think about this across systems, both inside your system and outside, if you have that.
Virna, speaking of that, we have two questions that are really directly related to this. And Des, I know, Des Stage, that number one, you are wearing pants for a change, and number two, you have some unanswered questions. Hashtag no pants, hashtag no problem. Des Stage says, in many healthcare settings, if you cite a patient as being at risk for suicide, providers will question capacity, kind of know, won't they? And then someone sort of on a related matter says, at student suicide, one of our great student members, does the banner ever go away, or once it's there, is it still on the top years down the line?
So we have had a lot of animated discussions inside about the red banner and when it goes away and when it should. So, some providers have the feeling, well, if someone's at risk, then, in some ways they're always at risk. And even though it may be years later, if some event happens or an anniversary, somebody could be at risk again. And then others say, there are people that, maybe years down the road, we don't need to ask them about their safety plan or do a Columbia scale every time they come in. And so we have now continued to keep suicide on the problem list, but a clinician can resolve it. And so it's still there and present. But the red banner might go away. One of the things we're thinking about doing is really trying to identify triggers or anniversaries for those patients and put them in a place where when you open the record you would see it. And so that might draw attention and people could get asked about it or have a discussion or note that if it might be a certain time of year. So we are trying to think about what that would look like, but that's been a huge topic of discussion.
So, and I'm going to say at VA, we leave our high-risk banners in place for an initial 90 days where we have a mandatory policy of care. And we do that because the evidence shows that first 30 days following where the acuity goes to high. And so we're looking for a risk that is high and acute, not chronically. And then so that first 30 days, they have very frequent visits, and they're a little bit less frequent. And then we review to see if the acuity has changed or if it's still acutely high. And we do it then very, very regularly after that with the goal of if your risk has been high and you go back to your baseline, we'll drop you back down to moderate. And we can always put the flag again if your level of acuity changes. And then we can always keep high risk for suicide or history of suicide attempt on that problem list where your primary care doctor might need to know that.
Yeah, what came up for us is we do a lot of assisted treatment, so buprenorphine, Suboxone for addiction in our centers. And unfortunately have had several completed suicides with patients who were in that program and getting Suboxone and buprenorphine. And so what I realized is for them that even though we had really documented that they weren't at risk, there had been a relapse or some sort of a struggle, and then they became acutely at risk. And so I really had some concerns about taking them off and resolving it for patients. So there's certain populations of patients that I still have some real reservations. I don't think I know enough to really be able to say comfortably that I want to sort of take that red banner off and not do something very definitive every time that they come in. And so I think, we're still learning, but that would be one population that jumps out. And we're very, proactive now about really trying to keep track of all of the patients who are in care, especially in those, in the MAT programs.
People are really, the feed is great, and people are really responding to how much is too much information in the medical record and how much is not enough, and the needs for not being stigmatized or discriminated against versus the needs to save their life. Stark is Stark, like, what are you hearing when you're listening to all this? I think you're also looking at the Twitter feed.
I am. You know, the one thing that I wanted to mention is that with all the innovations that Virna and the Institute for Family Health have done with their electronic health record, the Suicide Prevention Resource Center is working with Bernes and leaders from other healthcare systems to record all of this in an EHR paper. So people who work in other healthcare systems could go to their EHR vendor and in the tech language say, this is what we would like you to build in our system. And we're expecting to have that paper done in the next few months. When it is done, it'll be posted on the Zero Suicide website, zerosuicide.com.
In summary, if you are here because you're from the health information technology crowd and you want to advise people about how to set up their EHR, spark.org is going to, in fancy tech language, say here are the settings to get these better public health for suicide prevention sort of setups done. And there'll be a blueprint and you can just give it to people. Right? Did I get that right?
That's right.
Awesome. Oh, this is awesome. Virna, what are you hearing?
So, yeah, I also think that even if you're not a techie and you're, in practice listening to this or in healthcare, think about how you're managing your population of patients, even you as a provider. Do you know all of your patients who are at risk? How do you track them? How do you watch them? What do you do differently? And start to think about it individually and then try to make some system changes. So I think whenever we talk to people, we need to talk to individuals and say, what can you do differently starting tomorrow? And then how can you move organizational change? What kind of system changes can you make? And I think, to come at it from both ways is helpful.
I'm all about coming after it from all the ways. Let me tell you. But Bart, this feed is going really fast. I'm gonna have to duck unattended to this. Can you move it along?
Yeah, absolutely. And the feed, I mean, Virna, people are just popping all over the place with this. So I'm so glad that you're here. One of the things, thinking about as we start talking about, we have them we have suicide on the problem list. We've got red banners. There's lots of attention. There's lots of focus, which is really cool. From the patient experience standpoint, for the person who is deemed at risk of suicide, I think there's always concern for folks with lived experience that the treatment that we've gotten in hospitals and in systems sometimes has not been great, right? And often people at risk of suicide get treated in a way that it can be rough. And so I'm wondering when you guys have started doing this, what kind of feedback you've gotten from your patients? What have you done to deal with the person side, the bedside manner side to make sure? Because I think this focus is beautiful, and I think we could all learn from you. And if you could tell us about that side of it, that would be great.
Yeah, I think, one of the things that we've really tried to do is simultaneously train providers. Because then, providers, there are a lot of primary care providers that the minute they hear the word suicide or the minute, then that's it. And so I think that, we need to really train providers. And we've spent a lot of time doing that. And a lot of time training our behavioral health providers and all of the people in our system, because I've also spent a lot of years working in emergency rooms. And still actually do some work in emergency rooms. And it's so disheartening to see people come in. And I think this entire experience for this patient could have been avoided if someone had actually taken the time to have a conversation, if someone was trained to have a conversation. And so I actually really have always taken that experience and brought it back into the Institute and said, we are not going to be sending people, to emergency rooms unless, there are no other alternatives. We're really going to try to create a team that's going to work with people. We're going to say, who do you want on your team? One of the things that I'm thinking about now, and actually we're having a discussion tomorrow in our management meeting, is giving patients a menu of services. Here's groups, here's care management, here's individual, here's biweekly, here's weekly. Here's all of the things that you could pick from. Create your own team. Who do you want on your team? What kind of treatment do you want? And then that's actually the foundation for their treatment, and then doing some sort of a 30-day action plan. And this is for all patients, not just patients at risk for suicide, but that are getting behavioral health services. And so I really think that just conveying to people, we really care, we're glad you're here, we can really, who do you want? How do you see us putting together care for you, and how do you see, picking your team? And so that's something that we're thinking about. And
the Radical Record could do that?
Yeah, actually, because we've designed treatment plan traces in there so that you can actually, choose with people. And, we can also build, we're actually pretty fortunate to be able to build, things in the system that we need. And so even if you had something and you showed people and you let them pick and then, documented it in and had some choices and then print something out for them, So that's definitely the direction that we're going to be going. And I think that feels very different for people, and I don't think they've really been asked some of those questions. And so I'm hoping that really changes. And we've been talking a lot about to our, community advisory boards, as a federally qualified health center, 51% of our board is consumers. And so we also have advisory boards. We've had some focus groups around this. So we've really spent a lot of time trying to figure this out.
So, I got to check in about this.
Oh, yeah, go ahead, April.
So, are you telling me that you could, if someone, for example, had high risk for suicide on the problem list, that they could, as part of their EHR portal, say, we understand that these are the things on your problem list. Here are all the treatment options that are available. If these are interesting to you, click on this, and your provider will go over them with you and help you set that up.
Not on our portal yet. Do I think at some point I would love to put it on our patient portal? This is something that's going to have to start in the first visit with the provider, and then, but absolutely, I think at some point, the minute we can figure it out, we're going to try to put it on the portal.
Because I know an automatic push email like, thank you for your visit today, these things were identified, you should know we have these things in place to assist folks with these. If you will select some of these, someone will get back to you within a business day or whatever time period to go over the appropriateness of these options and help you set up your care. Yeah. People would click right. If it just involved getting the email and clicking through, people would sign up for stuff.
Yeah, and maybe we could even do that, before treatment, before your initial visit. So I think these are things that we're really going to be trying to figure out over the next year, because I think that's important. But we're absolutely going to go to some sort of a, even if it's written initially, some sort of a menu where people can start to pick options and sort of design your own treatment. And so I think that's going to be cool to see how people respond to it, and that's just patients.
That is technology-enhanced care. That scales up to do really patient-centered, individualized care. Like, that's brilliant. I'm sorry. That's awesome. That's a drop-the-mic, brilliant moment.
But I think that's where we need to go. And, one of the things we've also talked about is how do we identify people, and we've had a lot of conversations, and you talked a little bit before about disheartening moments, and I was actually just thinking, because Sarah and I were talking a little bit before, and you mentioned it, we have screening for depression, and a lot of times what we've realized in the last year or two that the people that we were losing, particularly in some of our upstate rural counties, had actually screened and not been identified at all in our system. So they were coming in and out, and we hadn't identified them. And so we thought, we have to kind of go back to the beginning here and figure out how we're going to catch. So one of the things that we're actively working on is to try to put a profile together to say, okay, you're a male between 45 and 60, which is the high-risk group for this county, and we're putting social determinants on the problem list, so financial problems, marital problems, employment problems, and if you've had 2 or more of those social determinants and you're a male 45 to 60, you're maybe automatically going to get the Columbia screen, full scale. So even if you come in for a flu shot, so what we did was they actually ran a report in the system of men in that age category, and we called them all up and said, hey, you haven't had your flu shot, you haven't had a colonoscopy, whatever it was, come on in and see your primary care doctor. And when they were there, we gave them the full Columbia scale. And we actually found that there were several men on that list who scored positive and were at risk for suicide that we would not have identified otherwise. And now, so I'm trying to figure that out now. What percentage was that? And trying to actually move it and do something across the whole county instead of that one practice. But that's something that's been a big focus and the topic of a lot of discussion. So I would encourage systems to really think about looking to see who's at risk in your system and then trying to figure out ways. I know that we work a lot with, some other behavioral health leaders around the country, and there's a woman by the name of Becky Stoll who is brilliant, and she did some profiling recently and, has figured out and is starting to do some of this work as well and screening people that might not have, 2 years ago we wouldn't have considered at risk because we didn't have the kind of population information that we're trying to gather now.
So I want to comment on this.
Oh, yeah, go for it.
So I just want to take a step back and make sure that everybody knows that most health and behavioral health care organizations in the United States could not tell you how many of their patients had died by suicide in the last year. Mm-hmm. So that's the normal.
They just don't count?
They just don't count. They don't count.
They don't know. They don't know how many patients they've lost to suicide. So compare that to an organization like the Institute for Family Health, who can not only tell you that number, they go back, do a root cause analysis on each death, figure out what the characteristics of those patients were and where the missed opportunities to intervene were. And now you have Virna telling you how they've changed their system in order to try to make sure that those deaths don't happen. So when she's talking about, middle-aged men in a certain age group with certain social determinants, that's because she's looked at the deaths that have occurred, and that was the profile of those patients. It's truly remarkable what the Institute for Family Health and Becky Stoll at Centerstone and a couple other leading organizations have done.
And I'm going to just be a little fouler because I don't have to represent anybody tonight but myself. But if you were a healthcare organization and you were letting people die by suicide and you can't even just make a little hashtags, I'm flying you the bird in my head. Number one. Number two, I'm serious. That's not okay. That's not okay at all that other people aren't counting. Okay. Second, we're having a lot of commentary, and Virna can probably speak to this actually much more eloquently and doesn't have to say anything quite so off color. But people are talking about, but if you have to retrain your staff and you have to monitor this and update your system, doesn't that cost money? And where are you getting the money for this from? Because we're so burdened. We're so burdened. Well, there's no money.
So, yeah, I mean, I think that's a lot what organizations say initially, but the reality is you're in business of providing care to people, and you're losing people in your system, and so how can you not pay attention? If you talk to healthcare providers, I guarantee you they're putting money into making sure people have colonoscopies, and they're talking to people about cancer screening, and they're talking to people. This is a public health issue. You can't not talk about it, and you can't afford to not address it in your system, and so I actually would say that, well, money is nice, and I think it's certainly helpful, to get some initiatives off the ground, but I feel like you need to figure out how to do this in your system regardless of whether or not you have funding. And one of the things I think is going to be helpful is to try to get some regulatory organizations on board. Joint Commission has a national patient safety goal, but if you look at some of the NCQA and some of the other primary care medical home and some of the others, you don't see suicide in there. And I feel like, one of the things to try to do is to talk to those regulatory bodies and say, what, this should be in there somewhere.
And I think you just said something really, because we've had now several tweets about funding. How much, does anyone know about roughly how much one ER visit for mental health distress costs or one colonoscopy costs? Does anyone know, like, the one cost for, like, one sort of routine scan of that nature? Probably not, because it's hard to know what anything actually costs in healthcare. So first of all, healthcare has all sorts of issues about funding procedures. But for example, when I needed to go get an MRI just to rule some stuff out, I had a fee. My agency had a fee, but we easily spent $1,000 or $2,000 just getting a routine scan to rule something out. What Virna is talking about, like where she's saying build into your EHR automatic screenings for things to reduce ER visits and improve life expectancy. None of those things are going to cost as much as one colonoscopy, one MRI, one mammogram. Not any of those things, I don't believe.
But there's a problem, and Virna maybe knows more about this than I do, but the way that the reimbursement system is built is that hospitals and physicians get a much higher reimbursement rate for technical procedures like a colonoscopy or things like that than they do for face-to-face contact like a suicide screening. So one of the big challenges that we have when they carve up and decide what the reimbursement rate is, things that are involved direct face-to-face contact get reimbursed at a much lower level, and there's much less margin and money in it for the hospitals than fancy technical procedures where they have to use equipment and those sorts of things, right? So there's a clear disadvantage. So it's hard to fund these things. They should be done, but when you look at how things get reimbursed, face-to-face contact, the most important thing you would think often gets reimbursed at a much lower level.
Virna?
Yeah, and I think, one of the things also is we've had a lot of conversations in primary care about addressing in primary care, and the reality is a primary care provider can see a patient for a depression care visit, a bipolar visit, a suicide care visit and be reimbursed at a rate, using their regular E&M codes. And so I think that, it's about making this a priority for them and helping primary care providers see this, as a public health and a primary care issue. And I think that, of recently some of the payers, particularly on the behavioral health side, have been good about paying some of the crisis codes, the 90839 crisis code, for a 60-minute visit. So in other words, to try to help people stay out of the emergency room, to provide some walk-in services, to provide some stabilization services. And so I think that's been helpful, so I don't disagree. I think we have a long way to go, but I think that, like anything, you sort of have to keep advocating and pushing the envelope.
That's what makes what you're doing so impressive, Virna. I mean, I don't know how to explain this other than as you're talking about what you're doing at the Institute, I start to get a little teary-eyed. Because, I mean, what you are demonstrating is what good, compassionate care, using data, using innovation, and that you can save lives. And I think that we've had other folks here that have gone to their agencies about zero suicide, and the medical folks have said, well, that's a mental health issue. That's not a healthcare issue. And that you guys have recognized that, in fact, suicide is a healthcare, it's a public health issue, and integrated it at every level. I wish everybody could do this, and everybody can. So hearing you tell the story, it's just so amazing, and it truly is. It's just very special. I don't know if you guys appreciate how special what you're doing is, but it is really, really cool.
Well, one of the things we did a couple of years back when we first looked at our data is we realized that we had more attempts in our mental health settings, but actually more completed suicides in our primary care setting. And we actually took that information and went back, and I did a presentation to all the medical directors and said, hey, here's a profile of, someone who's really at risk in our system. They're a primary care patient. They have a bipolar diagnosis. They have a history of substance abuse. And that was a real telling moment for them, because people realized, hey, wait a minute. And I actually pulled up some of the patients, and talked about them and talked about the last visit and pulled up the notes in the last visit. And not in a way to impose blame, but to say, let's learn. Let's really, this is a primary care issue, and you have the power to do something differently here. And really trying to educate. And one of the things we talked about a little bit off air was that was a huge moment for a lot of the medical directors, and it changed how they looked at bipolar patients, and it changed the questions that they asked, and it changed the effort that they put into connecting them to care, and it changed their perception in terms of how at risk they were. And so I think that, to try to do things like that with the primary care providers, and also to think, for population management, this is a big change for behavioral health providers to think about, what do I do with my population health really is new, to a lot of systems. How do I manage all my patients with, suicide risk? What do I do differently? Do clinicians even have a list? Even if you don't have a sophisticated electronic health record, start keeping a list, write it down. And keep a list. Here's all my patients who are at risk. I'm making sure nobody falls off the radar. I'm thinking about what I do differently. And so it's really important to start to even make some of these individual changes before you can, make some of the system changes. But the electronic health records, at this point, most of them have the ability to run a report so that clinicians, in Epic it's called Reporting Workbench, but it's the same in a lot of the electronic health records where you can run a report. All of my patients with bipolar, all of my patients with diabetes, all of my patients with suicide risk if you're putting it on the problem list. And it's important to start running those reports, and it's important to start teaching providers. It floors me how many organizations we talk to, and they have the ability to do that, and their providers aren't trained to do it, or they don't use that functionality, and that's really
And the primary care providers, make no mistake, are doing this for things like heart disease risk, blood sugar. I mean, this is not a new practice for them to make cases like that. It's just applying what they already do in primary care to high-risk mental health conditions.
Even if you add it, even if you have a diabetes registry and you say, okay, we're going to highlight all the patients with suicide risk on our diabetes registry. So use what you already have. Build on what you already have. If you already have a registry built, add to it. Even if you added at a very basic level, many organizations add the PHQ-9 to their depression or to their diabetes registry. So there are some very basic things that you can try to do. Decision supports, best practice alerts, those things, there are things that pop up when you see a patient to remind providers or people seeing patients to do things, right? They're kind of like little, flags, and they pop up and they say, do this, do this. They are common in all of the electronic health records, even if you put some decision supports in there, say, this patient is at risk, do something different. And so those are the kinds
and
of
the
things
record will do it for the doctor and for the nurse, for the team. And that is probably what a lot of mental health folks don't realize, is that we could have been managing this in primary care differently for probably the last 10 years.
Yeah, and I think, one of the things we're starting to do now, I love the fact that the electronic health record companies are coming to the table and saying, hey, we want to build this into our system. We want to make sure the Columbia scale is there. We want to make sure, that the banner is read. And so we've had quite a few meetings with, some of the different companies. And, again, Epic has been amazing and really trying to hardwire and offering support to any of the the Epic users. And so I think bringing the electronic health records, and what we're hoping we can move one along, two along, the others will then follow suit, because what you're saying is if you're looking at electronic health record, you want to say, well, can it do this? This is what we're thinking about doing for our patients at risk for suicide. Can we turn a banner red? Can we do these decision supports? Can we put this in a portal? And asking those questions, because the more times we ask those questions, or the more organizations that ask those questions, the more likely we are to make some changes.
I'm going to check in with Stark, because I've seen her react to several things. I want to let you know, that requires someone who understands primary care, someone who understands case management, someone who understands mental health, and someone who understands technology to sit in a room and solve a problem as a team.
Absolutely.
But Stark, what's your thoughts on this? We're getting towards the end. Are you watching the feed? Because I'm watching the feed.
I'm trying to go through the feed. It's going so quickly. It's hard to follow the whole thing. I just want to make a point here about leadership. That Virna Little is clearly a leader at the Institute for Family Health and with the Zero Suicide movement overall. And when I talk to organizations that are thinking about adopting the Zero Suicide initiative, we really talk about what you just said, April, that you need an interdisciplinary team with the physicians, the nurses, case managers, social workers, the front desk staff. You need representatives clearly from information technology. You have to get all of these people somehow coordinating the work in order to improve outcomes for suicidal patients.
Mm-hmm. And I also think, primary care providers, many times when they're picking electronic health records, the behavioral health providers are not at those meetings. They're not part of that process, and they're not, and you really need to be. You really need, I always say, if you're not at the table, you're going to be on the menu. And so you have to really think, how can I be at the table? And how can I, be inactive? Because suicide isn't going to come up unless you bring it up there. And so it's really important to be at the table.
We're going to say that one more time, because everyone loved that. If you're not at the table, you're on the menu.
That's exactly right.
Awesome. That's going to be the tweet of the night. I'm telling you that right now, Virna.
That was awesome.
So, Virna, we have one question that I'd hoped we'd have more time for, and that is, what is the future? Like as you're looking into the near and the sort of bigger, sort of the if you are wildly successful with the things you aspire to, what do you think the future is in terms of technology, suicide prevention, and primary care?
For us as a system, it would be zero suicide, which is something we aspire to, certainly. I think, we're looking at functionality now where community-based organizations can write in our electronic record, and so being able to do safety plans and change safety plans out in the community and then upload them into the system, I think is something that's going to happen over the next year for us. I think now we're embedding care management, and we're trying to, if someone's at risk, introduce them to a care manager right away, someone that might go out to the home, so that, you say, here's somebody, they're part of my team. You might be seeing them knocking on your door if we're concerned about you. So we've started doing that a lot. And Bart actually mentioned in the beginning caring letters. And we've spent a lot of time developing caring letters and sending them out. And Bart, we should talk about it outside. We're actually doing a project now looking at the response to caring letters sent out to patients and trying to do that. So I think that's something that we're definitely going to be pursuing.
Virna, for people who don't know what caring letters are, can you briefly describe it?
Oh, sure. So, a lot of times when people don't come in for appointments or essentially don't follow up with treatment, or we lose track of them, we would send a letter, Dear Sarah, you didn't keep your appointment. If we don't hear from you, we'll close your case, or please reschedule your appointment. These sort of very dry, sort of standard letters. And a caring letter is done by the clinician that says, Dear Sarah, I missed seeing you last week. You came in and you shared and you talked about your family, and I'm very concerned about how you're doing, and maybe mention something. okay to share in a letter and specific enough so that it feels personalized to somebody, and then hand signing it from the clinician to say, so it's a little bit different, it's much more personal, and it says, I was really glad to have an opportunity to meet you, and I really missed seeing you last week. And I think that can make a huge difference for someone, and we've seen some good responses. And so we actually did them for our patients at risk and had the primary care providers sign them. Took them around and had primary care providers sign them and sent them out and followed that over a 2-week period and saw some good response. So now we're going into our 4-week period to do a checkup, and we'll see how that goes.
And that's an evidence-based practice. I mean, Virna didn't make this up. This is one of the very few things we know that actually reduces death. So safety plans, means restriction, caring letters is like right now, one of the very few things we know that a system can just do. And I mean, Virna, you're saying that the EHR could even prompt somebody to send a letter like they haven't been in, they missed their appointment, write them a letter.
Yeah, we can absolutely do that. And I think if you really look at the effectiveness of sort of those, programmed letters that can go out to mass numbers of patients, I think that's okay if it needs to remind you to go get a mammogram or something. But I think if we're talking about engaging patients at risk for suicide, it's completely inadequate. And actually, I think it sometimes, hurts our efforts. And so I think that it's helpful to try to do something a little bit different.
We are hitting the last 5 minutes, Virna, and this is typically when we do final thoughts. And I am going to be really sweet to Stark because this is her first night to do it live. So what we do is each of us sort of go through what we think the big take-home message for the evening is, and I'm happy always to go first. For me, the big take-home message for everyone is that a great deal of practical things are possible if somebody sits down at the table with someone who understands suicide prevention, people who understand basic healthcare and basic healthcare strategies, and people who understand technology, and talk about, well, we have this happening, here's the data, and an integrated team looking at data can do a lot with practical problem solving to move the needle on reducing suicide death.
Absolutely.
Bart.
So final thoughts. One, just watching the feed, and this is so true. Stark said at the feed, saying that Virna, you are a leader, a nationwide leader in changing the landscape around suicide prevention, healthcare providers, and doing a beautiful job at it. So I just want to say collectively thank you. What you're doing is so important and so special. If folks aren't picking up on this, this is the future. The things that Virna is talking about, integrated healthcare records, integrating mental health with all health, that's all one thing. Across interdisciplinary connection, everybody's involved, being thoughtful, planful, and thinking about the lived experience and how that connects. This is the future, and you guys are doing it so well. Thank you so much for being here and sharing this. It's been magical.
And Stark.
My final thought is extremely easy. If you would like to join us and Virna Little in changing the future of healthcare to realize a world with zero suicide, visit zerosuicide.com. You'll see a bunch of ways you can get involved and keep in touch with us.
Absolutely. Virna, final thoughts for you for the evening.
So I want to thank everyone. This has been an incredible amount of fun, so thank you so much. And I also, want people to be inspired. I hear a lot from clinicians, I can't change my electronic health record, it's overwhelming, I have no power to change anything in the system. And so, think about things that you're able to do differently tomorrow around caring for your patients in your system, what you can do in your system, and then try to really continue to be at the table and bring it to bring it to the attention every opportunity you have, but be inspired to make changes.
Be inspired to make changes. That is the actual best tweet of the evening. Be inspired to make changes. You have spent another Sunday night with #SPSM. You're not getting it back. I don't care if there is a blood moon out there, Julie Cyril. Thank you so much. We probably don't thank our audience enough. Thank you so much for what you bring, because the truth is that we wouldn't get to do this if you guys weren't out there making it so exciting for us to talk about this issue that we're passionate about. Do remember that you can find us at spsm.com or spsmchat.com. Do remember that you can find SPSM on Facebook, and you can also find the Institute of Family Health on Facebook. You can like their page. They'll chat with you. There's a person. Her name is Erin. She's behind all this wonderful stuff, including the tweets tonight. Thank you to Erin. Thank you to Sean. Thank you to Virna, to Pocket Square, to Stark, to all of the people, and of course to Tony, who tirelessly and silently often makes sure that our tech runs every week. Tony's given us the big hey. Do remember, too, that this is the end of Suicide Prevention Month, and we ended on purpose talking about primary care, where we believe 80% of mental health is provided and where we have a better chance of reducing deaths by suicide. Talk with your healthcare systems. Let them know that this is important, and let's see if we can move the needle. And everybody have a great night. Take care.
Good night.
Good night.
Night.